Hello, everyone. Good afternoon. I think we're going to get started right on time this time. And thank you, everyone, for being here today, both in person, and I'm sure we have a few virtual attendees as well. Again, thank you for being here to hear about AI and prior authorization. As I was telling some few people before we got started, we are required to set up these things starting in February. And so for us on the health side, it's hard, what issues are going to be, from February to September now. But we figured, as you know, prior authorization has become a big hot button issue. So we thought it would still be relevant in September when we were starting to plan in February. So again, as you know, prior authorization is becoming an important hot button issue at the NAIC as well as in other spaces. And currently, our regulatory framework task force was assigned a task to develop a white paper on prior authorization, so that's working through. And then, as you know, recently AHIP and Blue Cross Blue Shield Association announced that some of its members are prepared and committed to streamlining and simplifying the prior authorization process to make it better for all the stakeholders, consumers, insurers themselves, and the providers. And so today we have a distinguished panel of three to talk about prior authorization from the three perspectives: consumer, regulatory, regulator experience, and finally the carrier insurer perspective. And so beginning, we start with Lucy Culp. And Lucy is Vice President, State Government Affairs at the Leukemia and Lymphoma Society. I think they just recently changed their name. Lucy leads a team of government affairs staff who advocate for state-level policy change to ensure blood cancer patients have access to affordable, meaningful health care. Prior to joining LLS, Lucy spent nearly 15 years at the American Heart Association, where she worked extensively on state implementation of the Affordable Care Act and a wide range of other healthcare and public health priorities. Lucy also serves as an NAIC consumer representative. And then next we have Matthew Pickett, or Matt. Matt is the health policy coordinator at the Illinois Department of Insurance. He handles health care and health insurance policy for the department. In his role, Matt drafts and analyzes legislation, reviews regulations, and leads department health meetings and represents the the insurance department on several NAIC task force and working groups. He worked to pass the Illinois state-based marketplace and the pharmacy benefit manager reform legislation, and has worked on other key items such as mental health parity and ground ambulance billing protections. And then lastly, but not least, we have Anju Chowdhury from the Blue Cross and Blue Shield Association. Anju is the Vice President of Policy and Development and Strategy for Blue Cross and Blue Shield Association. He has been with the Blue Cross and Blue Shield Association since 2005, serving in multiple capacities on both the clinical and policy teams. In his current role, Chowdhury oversees the development of Blue Cross Blue Shield Association's public policy positions and strategy for use with the administration, Congress, and government agencies, state regulators, and third parties. He guides staff in the formation of Blue Cross Blue Shield Association's positions on current legislation, regulation opportunities to improve the healthcare system across commercial markets and government programs. And with that, I'll turn it over to Lucy to start us off. Thank you.
Thanks, Jolie. Hi, everyone. As Jolie said, new name. The LLS is now Blood Cancer United, so new name, same mission. We serve blood cancer patients, and as you can imagine, those are folks who have really complex diseases to treat, and so are interacting with the healthcare system and their health insurance company a lot, and so face issues around utilization management and prior authorization, which is really what kind of brought me to these issues, but kind of for the purposes of this conversation, really thinking about this through the lens of a consumer representative to the NAIC. So for folks who aren't familiar with the program, it's been around for about 30 years. There are this year 42 consumer reps that serve in this role, and really with a wide range of expertise, folks like me who focus on health insurance, but also folks who focus on life, property casualty, climate, mental health, auto, pet, really kind of we run the gambit. And if you're not familiar with the program, we're really here to be a resource and a partner to regulators. We focus on a whole variety of issues as well, kind of based on our own expertise, but also based on just kind of what's moving and shaking at the NDIC and where we think we can be helpful. So it's sort of not surprising that we've gone pretty deep lately on issues around prior authorization, but also on issues around AI and where the two meet, right? Which is really why we're all here. So I want to talk a little bit about a report that we issued late last year. The health reps kind of put this together in partnership with NORC at the University of Chicago, really looking at we wanted to focus on utilization management as we were thinking about AI, particularly because that's where improper denials of medically necessary care really have the most risk to consumers. So the researchers at NORC, they conducted a number of in-depth key informant interviews. They talked with folks at health plans, thought leaders, consumer advocates, providers, regulators, tech experts. They also did a really extensive environmental scan and then kind of synthesized all of that into a report for us to kind of help us understand, what's the lay of the land when it comes to AI use around prior authorization and how does it impact consumers? So at kind of a high level, what the report said, really the findings kind of fall into three buckets, right? It's plan use, it's the impact of that use, and then it's what do oversight and regulation look like. So when we think about plan use, right? AI is regularly used by health plans to conduct utilization management and prior authorization activities, right? The evidence was really clear there. And while there are real opportunities for reductions in administrative burden and expedited approval, there's risk that has to be considered too, such as exacerbating existing bias or unintended harm. So what's the impact of that, right? It's the stakeholders that the researchers spoke to, they really see immense opportunity, again, in the use of AI, but warn that proper safeguards need to be in place to protect patient access to medically necessary care and to ensure that privacy and safety are appropriately considered. And then lastly, that while some states have begun to regulate the development and use of AI in health insurance, for the most part, this technology is moving fast and it's hard to keep up, right? So regulation in this space is in its early stages, and with the speed that change occurs, it's a really challenging but really essential problem to solve. So I want to just share a couple of the kind of notable quotes, and I'll just keep this here for just a second, but I think it's just, you see it right in these quotes from health plan executives, or from a health plan executive, it's the opportunity, right? There's real opportunity in this use. From a consumer advocate, it's yes, there's opportunity, but there's risks, and we have to really think about the risks. And then when you think about, kind of on the tech side, a technical expert, it's really that importance around testing and monitoring on an ongoing basis. So to dig in a little bit more on kind of what we found when it comes to plan use, the researchers, they gave us kind of three examples to really help us break this down and understand, right? So there's administrative only kind of at the top, and this is kind of the most basic application where AI really serves as like a document processing tool, sifting through multitudes of documents to collate the relevant information for that human case reviewer. So they're gathering data such as medical history, insurance denial or details, clinical guidelines to create kind of a summary report for the plan's reviewer, who is then assessing the prior auth request. AI doesn't make the decision, but it improves the efficiency by reducing manual data collection and kind of moving the process along faster. But that ultimate decision, whether or not to approve or deny the claim, lies solely with the human reviewer. So kind of the second bucket there is decision-making support. I realize my little chart is really small, so I'm sorry about that.
But it looks professional.
But yeah, but you'll get the slides. So, the decision-making support, right, is kind of that middle tier. And that's where the AI is conducting that initial review of the prior authorization request based on a predefined criteria. It may automatically approve low-risk routine treatments while flagging others for human review. And though the AI can approve requests, again, based on predefined criteria, it's not denying them, right? The denials are still going to human oversight. And this model, again, it has this opportunity to increase efficiency, but limits human interaction in some of the approvals. And then lastly, and this is kind of the most robust example, is that kind of learning model. So this is really advanced application. It allows the AI to approve, deny, or escalate cases based on an initial criteria and then evolving, learning data. So it adapts over time by learning from human reviewers and from their outcomes and then adjusting future decisions kind of based on that. While this model can enhance efficiency and decision accuracy, it also, as you can imagine, poses some more risks because if the AI is learning and basing decisions on flawed or biased data, it may reinforce errors or even inequities in care decisions. So these examples are really just meant to kind of underscore the importance of tailored, responsive AI regulation that reflects kind of the varying roles and risks that AI may be being utilized or playing in this prior authorization process. So again, to kind of go into, okay, so how is this impacting consumers? What does this mean, right? In the absence of really comprehensive, federal regulation for AI and health insurance, stakeholders have begun to identify what these risks look like, what the impact looks like. And through a variety of sources, right? There's quite a bit of study, academic study, there's, news reports and deep investigative reporting and lawsuits and, a variety of ways that the researchers were able to get a better picture of what's happening. And, primary concern is if and when AI tools are trained on biased data sets, which, you can imagine can perpetuate existing disparities. So an example that they called out was, there are past clinical standards for kidney disease that include race, right? They're part of the assessment. And those have now been shown to produce worse outcomes. They're not part of clinical guidance anymore, but if an AI tool isn't, very frequently updated to reflect the most recent guidance, you can see how there's a risk that it could reinforce these old biases. Transparency and explainability is also a really key concern. Many AI models are using proprietary data and decision-making criteria that are not publicly disclosed. So it makes it difficult, right, for patients or their doctors to understand why a denial maybe was made and know how to challenge it or appeal. And then further, misaligned incentives in AI may prioritize, say, financial considerations rather than medical expertise or medical evidence. And there's real need for, again, transparency around the criteria for clinical review and to review those denial decisions. And then finally, machine learning systems that evolve over time, right, as I said before, kind of pose an even more significant risk if left unmonitored. So, I want to make sure, I'm realizing our time is, okay, keeping an eye on time. I want to just dig in on this last set of the key findings here, which was really all about kind of the regulatory landscape today. And again, kind of in the absence of federal regulation, states, you all know, states are the tip of the spear here in developing your own approaches to, overseeing AI use and particularly when it comes to prior authorization as we think about health insurance. Matt's going to go into this a lot more, so I won't go into it to a great detail, but I will just, plug our report here because while it does look generally at state legislative trends like AI task forces and studies and transparency, meaningful transparency, but transparency, the report actually digs into what a couple of states are doing that's, a little bit further along. So Colorado, Utah, and California are all highlighted in the report. But then we also went into, what are other stakeholders in the healthcare system saying, what frameworks are out there, what other resources are available, and those are all in the report too. So I realize I should have put, fancy QR codes so you could have gone straight to the report, but I promised to share the email, the address, and you can email me. I'll send it to you. So last thing I want to cover before I hand over the mic is just the recommendations. So here, I mean, the consumer representatives, right, we, based on kind of what the researchers shared with us, what they found in their study, we have a number of recommendations for states, for regulators to consider as you're thinking about, again, how AI tools are used in prior authorization and what the regulatory framework for that looks like. First of all, meaningful transparency is crucial, right? If we're talking about quick approvals, that's one thing, but particularly with denials, it should be really clear to regulators, to providers, to consumers, what role an AI as a tool is playing in making that coverage determination. And transparency for regulators in particular should extend to disclosure about the data being used to develop, train, and then test these tools. And really the extent to which any AI tool can begin to train itself. Second is accountability. You know, AI tools intended for prior authorization should be built on clinical guidelines and standards of care that aim to, right, achieve the highest level of care for patients and consumers. Health insurance plans should be held accountable for improper denials, and regular audits, even, you know, if conducted by, say, like third-party agencies that specialize in AI tools, but on behalf of regulators, are a really good way to both, you know, understand what's happening and to hold plans accountable. And then lastly is oversight. You know, regulators, we would really encourage you to ensure that when AI is used by health insurance companies to make coverage decisions, that there is oversight by humans with appropriate clinical training, right? That there's that human in the loop. And that there are not undue consequences for humans who overturn decisions that were recommended by the AI tool. I think that's a really important piece to consider here too. And that, you know, robust and accessible appeals processes, right, we know are critical. They're especially critical in this landscape. And again, to understand how and if AI is playing a role in the denial. And then lastly, that, you know, this should really be considered an evolving practice because it is, right? The technology is changing fast, its use is evolving, and there are, you know, a lot of interested stakeholders, collaborators, tech experts, folks like me, consumer reps, who, you know, are really willing to partner with you to kind of help this in this continuing evolution. So I will pause there and turn it over to Matt.
All right, thank you. All right, thank you, Lucy. And for the record, I've read your report. It's really good. Hi, everyone. Matt Pickett. I work for the Illinois Department of Insurance. I work for the director, handle healthcare policy. For those who have not had the chance to meet me, if you've been on a WebEx meeting, I'm the pug. So if anybody has been on those, I'm Charlie the pug. So yeah, just for reference, I wanted to make sure I explained who I was. I realize I have way too many slides, so I'll go through as much as I can before I have to hand it over to Anju for his portion. I'm a classic over-explainer, so I apologize, but I'll try to get through as much as I can in the time allotment. I had about a 5-hour drive over here, and something I was thinking of on the way over, my older son is very literal, and he's taking government right now, and I'm trying to explain to him as he's getting ready for college. He's a senior. You know, buddy, you got to think outside the box. And then I thought to myself, I probably should have used that advice when I was doing my presentation, because if we have to think outside the box for anything, it's a field like AI in a field like healthcare and health insurance. So we'll go ahead and get started. We only know what we only know. We don't see AI being used in the process itself. What is truth and what is fiction? We, quite frankly, have very limited tools at this point to differentiate between those two. It's being used for claim processing, but not medical necessity. This really isn't the most easy thing to corroborate. Third-party use is a conundrum for legislators, for regulators and legislators. We have not seen and dealt with it before. It's difficult to lend insight into the complex and often unregulated field, and we can only take the actions that are granted or given to us by legislators by statute or regulation. What are we seeing, and what are the implications of AI in prior authorization? We've worked with all stakeholders on prior authorization updates and reforms, but we've noticed that the actions that have followed since then contradict the efforts to improve the system and improve customer care, or consumer care, I should say. We had an entity that informed us that no medical utilization reviews were being done and claims denials were being done, but then they provided advice on how to issue denials, reductions, and payments. What does that mean, and how does that work? And we don't know. It's difficult for us to corroborate. Entities use utilization review programs to determine medical necessity based on the locations, sites of care, or settings. These are contradictory to our insurance code, and so we have sought guidance from NAIC. We even had to issue a company bulletin that reminded carriers and issuers to follow the code and our own mental health parity standards, because that's where we specifically have seen it. There are troubling trends in MHSUD and prescription prior authorization spaces, and this is just what we find. So we're only seeing what we're actually able to get under the hood and take a peek at. And inconsistencies in situations make enforcement very difficult. And unfortunately, as Lucy attested to, consumers are often put in the middle, kind of like we are sometimes between both advocates and stakeholders as well as industry. What do these actions mean for us as regulators? Adverse actions pit industry. Adverse actions pit industry. But you know what? I have that wrong. I apologize. It pits us between industry and stakeholders. So we're oftentimes caught in the middle. Limited resources means a limited ability to enforce the laws and the regulations, and that may not be the case for all departments of insurance, but something that we see at the Illinois Department of Insurance is that is certainly the case. A lack of clarity makes it hard to recommend legislation and regulation or react to legislation and regulation. Folks look to us for answers and perspectives, but it can oftentimes be difficult to lend insight in the space. And then developments and practices are not isolated, so we seek input from NAIC and then a lot of other regulators in other states. What can we as regulators do? We serve a key role in ensuring proper and ethical AI use for prior authorization, utilization management, as well as step therapy. How, when, and to what degree we actually push back is a conversation that we have to have internally quite often. We have to handle cases as complaints, and we have to work with entities to properly apply standards of care. It's an ever-changing field, so it presents us challenges that we have never faced before, at least as regulators. We realize that AI is not siloed into prior auth, and that it actually is being used in all facets of health as well as insurance as well. And then developments and practices are not isolated. I'm sorry, I went back, I apologize. Regulators must be proactive, and just like issuers, providers, and developers are, we have to follow the same path. And then regulators and decision makers must work together, and that's a key thing that we see, whether it's on Capitol Hill or in Springfield or any of your state capitals. We have to work with the folks that actually pass the legislation and make it happen. We issued a company bulletin last year, 2024-08. This is our company bulletin that we basically co-opted from NAIC's. It adds the definitions for adverse consumer outcomes, AI and AI systems, as well as third parties. It delineates all the authority that we have via legislation and regulation to enforce AI conduct in the state. And then I'll let you guys read some of that, but basically it requires them to document AI use and reliance, third-party developments, maintain an AIS program, and then mitigate adverse consumer risk. It expects an issuer's AIS program to address AI usage for claims of fraud detection. It expects issuers to document AI usage, reliance, third-party developments, data quality and integrity, bias analysis and minimization, program policies, protocols, and procedures compliance, as well as third-party contracts. It allows us to review AI documents that were referenced above. It places a great emphasis on unfair trade practices and discrimination, and encourages the development and use of verification testing to identify model errors and biases. And then it expects predictive models to include error detection and unfair discrimination, as well as predictive model development documentation, validation, and testing. So that's something that we enacted as a department about 1.5 years ago, and as I'll get to in a minute, it kind of dovetailed then into some of the efforts that we've worked on with the governor's office and some legislators to better regulate the space. And then here's some questions that we must ask. What is the best approach? What can we learn from NAIC? What can we learn from other states? What can we learn from advocates? And what can we learn from industry? And we work with everyone. We have to, and we may as well utilize each other's expertise and insights. Otherwise, we're kind of flying blind on this. What can we glean from a market conduct exam? That's obviously a hot topic right now with items that we're seeing in fields like pharmacy benefit managers. So what can, even though that's not necessarily related to AI, what can we learn from those exams? How can we apply those types of exams to AI in relation to prior authorization and utilization management? Can we utilize partners to help us oversee our efforts in AI regulation? What is and is not medically necessary, and who determines that necessity? We don't always see that, so that's something that we constantly have to ask and we have to dig into. What are some implications of state law? How is it applied? And what can we glean from the AI health survey that the NAIC released? You know, that's a fascinating survey. It's great to read through, but what can we take from it, especially as we make decisions as regulators and advise both decision makers and legislators in this space? So we'll do a quick thing on how did we get here. Here are just some laws and some regulations that we've taken. The big thing that we did a few years ago, right after COVID, and my coworker Miriam will remember this because she and I were both in the Senate when it passed. I don't remember it very well because anything after COVID with legislation was kind of a blur at this point. It was not our bill, but it laid the groundwork for future prior auth proposals and reforms. It defines prior authorization, appeals, and medical necessity. It requires issuers to maintain a prior authorization list and requires clinical review data to meet guidelines and standards. There's a big one. It requires a physician to make adverse determination and handle appeals. And that is something that we keep coming back to because we keep seeing in reforms and proposals that this is an issue that is clearly at the forefront of legislators and advocates that we work with on a regular basis. It also sets parameters for claims denials, prior authorization changes, and approval lengths. So that passed, I think, 4 years ago. And then early last year, we started working with industry and stakeholders on this. This was our utilization review and adverse determination reform package. And this was, getting this through the General Assembly was a slog. It was very, very difficult. We basically authored this in response to developments that arose after the passage of the Prior Authorization Reform Act. So that's one of those legislative landmines where, since the reform package wasn't ours, we had to do the delicate balance and tiptoe around how do we make this work, considering the fact that the legislation package was not ours in the first place. So we had to update the definitions of adverse determination and expand utilization review to include any evaluation based on algorithmic automated processes. That was a big one. Getting legislators to kind of grasp what we were trying to do with that was not easy, but we finally broke through on, and that was one of the big topics that we had to work with them on. It further defined adverse determination to include both unilateral and final determinations, and it strengthened language pertaining to clinical peer reviews. We were able to require accreditation for any URO through either URAC, NCQA, or a similar entity. It set new guidelines for UROs to apply the algorithmic automated processes and required them to adhere to a new set of requirements that were codified in statute and then also bolstered by the rules that we've issued since then. And it allowed a professional automated process to certify the medical necessity of the service in accordance with accreditation standards, either through URAC or NCQA. So we got that through, and then right around the same time, we passed the Healthcare Protection Act #1. This was Governor Pritzker's big legislative lift that he did last year. We worked with him on it to get it through the General Assembly. It required all utilization review organizations and programs to make medically necessary determinations in line with nonprofit or third-party guidelines. And even though that does tie into the reform package that we passed, that was the intent, was we had to pass both around the same time in order for the package to work and actually help consumers and make our lives as regulators a little easier. It required programs to guarantee placement at the level of care at or above the level that was ordered by the treating physician, which was also a big deal that the governor wanted to get through. It required health plans and UROs to review programs to follow specified criteria. And here are the big ones. It prohibited prior authorization for in-network, inpatient mental health services and prohibited concurrent review for in-network, inpatient mental health services for up to 72 hours. So it was part of a bigger mental health parity push that we've engaged in the state as well. And then last but not least, it prohibited utilization review programs from imposing step therapy requirements and updated our utilization review and utilization review criteria definitions to protect consumers from prospective, retrospective, or concurrent review. So we essentially banned step therapy in Illinois, and we realized that this is again, part of a bigger package, and we wanted to ensure, since we knew AI was going to be used in the space, that we included step therapy to cover our bases. And then this year, we passed the second version of the HPA, which was HPA number 2. It built off the success of the first one. It was proof positive that we can build on successes and work with stakeholders in industry to improve consumer access and protections while working with industry and advocates. And then the big takeaways are it prohibits mental, behavioral, and substance use disorder coverage from being subject to concurrent review, prior authorization prior to the notification deadline, and it prohibited prior authorization for in-network outpatient mental health services, and it requires issuers to either follow a 24-hour or a 2-day notification protocol. So that was a big task, and we noticed that that's happened in other states, so we were finally able to get it passed in Illinois and part of our insurance code. And then something that's not quite AI related, but an item that we're going to have to look for as time goes by, is we also now require carriers to reimburse for MHSED travel expenses. So we know that that will be something that we'll have to keep an eye out for when we do our mental health parity exams and ensure compliance. And then I don't have enough time to really go over the next one. This is our market conduct exam expansion. This basically allows us, it gave us expanded market conduct authority, and it allows us to work with NEIC and requires carriers to open the books and allow us to get a full look at what they're doing. And since we just passed pharmacy benefit manager reform this year, this was something that we had to pass in advance of that, and it laid the groundwork for our ability to go in and actually see what companies are doing. And then what does the future hold? I'll run through this really quickly. You know, I know in the general session they talked about how the big beautiful bill, and I know a lot of people hate that term, but I'm just calling it what it's called. It did not put a moratorium on it, so we're actually able to pass legislation and be reflexive. Regulators and decision makers can work with NEIC to continue shepherding the model law through the process. So, you know, we're willing partners. We just want to make sure that we're actually able to put into practice what the NEIC is working on. We can utilize the systems that have been introduced as soon as they're released. We can take all the knowledge and tools from the meetings and the summit back to our states and work with stakeholders, decision makers, and legislators as well. We cannot and should not be afraid to make bold decisions. And something else is we have to remember that we're all learning. So when I work with my team and then we speak with advocates and we speak with industry and we speak with legislators, we have to remember that none of us are experts in this field. Some people may be, but we're not. And we have to put that in perspective, because if we don't, we won't be able to properly convey what needs to be done and be willing partners. So thank you guys very much, and I'll hand it over to Anju. Oh, sure.
Sorry, the clicker.
Oh, sure.
Thanks.
Now you got 2 microphones.
Hey, everybody. Thanks for the time today. So my name is Anshu Chowdhury, and I'm the representing the Blue Cross Blue Shield Association here today. And I'm trying to get my slides up. Here we go. In my presentation today, the promise and responsibility of AI in prior auth, I'm going to talk through several ways that Blue Cross Blue Shield companies are using AI in prior authorization, some of the things that we're doing to hopefully build consumer trust and safeguard against any adverse consequences. I'm also going to talk about some of the commitments that we've made with other insurers across the industry to improve and streamline prior authorization. And then I'll wrap with some just recommendations as we work with NAIC. So prior auth, we're all familiar with it. Why do insurers use it? And it's really used to balance different priorities, so quality, safety, and affordability. On the the safety side, health plans have in-house staff, clinicians, physicians, nurses, pharmacists, other clinical experts that are responsible for tracking the literature, keeping up with the science and the evidence base, and then helping us make determinations on what's covered under medical policy. And then with that, that's where prior authorization decisions might be made on what might require prior auth based on the level of evidence or sometimes the cost of care as well. As we work with our contracted providers, many providers are doing great work. Occasionally, there might be things that are prescribed or services that are recommended that either may be out of touch with evidence-based guidelines or maybe the evidence is not quite as robust for something. And so health plans will step in with prior auth, want to see if something was done first versus going a particular route. An example is stomach pain, abdominal CT that exposes the patient to radiation. An ultrasound could reveal the same information. So having a patient go through that first rather than the abdominal CT is some place where prior auth may come in to try and protect the patient from any unnecessary exposure to radiation. And then related to all of this is affordability. So we are asked to be stewards of the premium and the healthcare dollar. And so with prior authorization, oftentimes it's put into place to ensure that there aren't, if something is being prescribed and there is a lower cost, equally effective therapy that's available, that may be tried first, or if there's a different site of care or setting for something, maybe it's switching from inpatient to outpatient, it can lead to significant savings for the patient and obviously impact on premiums as well. So AI, where does AI come into all of this? AI is a tool that can help streamline the process. And so make it faster, more accurate, and then also lead to less burden for providers as well as patients. It's a tool, as Lucy talked about earlier, it's a tool that is being used to try to kind of move to more real-time approvals of things and make sure that documentation and burdens that are associated with submitting paperwork and back and forth can be streamlined. And if there are gaps in documentation, which is often what comes up when things are initially denied, AI can help identify those right away and then help move to a more quick approval. So how responsible AI use is improving prior auth. So one thing I want to say just to kind of emphasize is that Blue Cross Blue Shield companies are using AI as a tool to support and not replace human interaction, clinical expertise, and human judgment when it comes to prior authorization. So it's to support and not to replace. We understand that innovation and AI, it's a very quickly evolving space. It's one where there's a lot of potential for good. There's also potential for harm. And so our plans have really been working in their adoption of AI to make sure that there are balanced safeguards to protect patients and maintain trust. We are using AI to reduce processing times, as I talked about. So across the Blue system, many Blue plans are using AI to automate approvals to less than 90 seconds in many cases, and then quickly flagging where there might be gaps in documentation, which often is what slows down approval processes. AI can help identify those right away and make sure that the provider knows what's needed, and then we can kind of move more quickly on that, getting to that approval. On improving the consumer experience, so in many cases, members will call their health plan and ask for clarification around is prior auth required for this service. And where prior auth is helping our customer service reps is being able to retrieve information much more quickly on the medical policies, what might be needed as far as documentation goes, what might also be needed if there are other alternatives that might be recommended first as a lower cost type of option, or potentially even a safer option for the patient. So AI is helping with our customer service reps to be more personalized in the way that they're giving responses and more consistent in the responses that they're giving to members. Implementation of federal regulations, this is another one. So AI is supporting us in implementing the CMS interoperability and prior authorization final rule. Many of those requirements take effect in 2027. And so plans are using AI to build digital tools to let providers kind of submit information in a more seamless way electronically, and then track prior auth requests much more easily than before, so that patients and providers have more transparency into the process, what's going into any potential delays that may be happening, and then what might be needed more to move things along much more quickly. And so, and all of this is being implemented with more safeguards that are built in. Many plans have built in internal AI governance structures that are heavily informed by the NAIC's Model Bulletin from 2023. They've also adopted national standards, so NIST put out the AI risk assessment framework. So plans have been using that to guide responsible use of AI. And this includes greater transparency, doing what they can to reduce any potential bias, so making sure that the inputs are not leading to garbage inputs are not leading to garbage outputs or creating any unintentional bias. And then also that maintaining the human aspect of this and human oversight. And so all of this is hopefully plans taking a more thoughtful approach to implementing artificial intelligence, but then also streamlining the process and hopefully building consumer confidence along the way. So, while, at least speaking for Blue Cross Blue Shield plans, while the vast majority of Blue Cross Blue Shield claims that go through the system, it's probably close to around 95%, do not require prior authorization. It's the 5% that do that we know that probably all of us in this room have experienced at one point or another, and it leads to the greatest frustrations as far as getting the care that may be prescribed or the care that's needed. And so we know that the prior authorization process can be improved, and it's something that we're working to do, not just through AI, but through a number of other commitments that we got together with other industry leaders over the course of this year, and it was announced in June, industry-wide commitments to improving the prior authorization process. And making sure that it's one that's working better for providers, it's working better for patients, and by simplifying and streamlining a lot of the things that we had required in the past related to prior authorization, we're hopeful that it will make things easier for us as well too. And so this industry-wide pledge builds on some momentum that was already there in finding ways to try and improve prior auth, but then also we built this in consult with patient advocacy groups, with providers, and with healthcare systems to figure out what are some of the core things that would be the most meaningful in this space. And so I'm going to take a few minutes and kind of walk through each of the things that you see on the screen here. So starting with standardized electronic prior authorization. So this will take effect, and we set some self-imposed deadlines on some of these things. And so starting by 2027, so January 2027, plans have committed to moving towards a more common framework for electronic submission of required information. So what does that mean in reality? If you're a provider, and going back to that abdominal CT example I gave earlier in the presentation, if you're a provider and Health Plan A requires prior authorization for that abdominal CT, but says it's going to be 3 forms and 27 data elements, Health Plan B also requires prior auth for that abdominal CT, but it's 1 form and 10 different data elements. The industry has agreed to move towards a more standardized way, so it's the forms look the same, and the way that you submit the information electronically is going to be the same. So it's the same data elements and the same forms that you can work from, so that it's going to be much easier to do the same type of prior authorization request multiple ways for different providers. This builds on some of the FHIR APIs that are out there that will make it help with making that much more seamless. The next one on reducing the volume of prior authorization, this is what it sounds like, reducing the volume and trying to lower the number of medical services that are subject to prior authorization. And so this will apply across lines of business, so fully assured, Affordable Care Act, Medicare Advantage as well. And so plans are going to be reporting on progress made towards this. So this is starting in January of next year. But we realize that going back to my statement earlier, where even though 95% of services on the medical side aren't subject to prior auth, it's those 5% that people feel the most and that people get frustrated with the most. And so how do we go about finding a better way to streamline what does require prior auth, and in the public reporting of that too, because we know that's going to be a big question, is whatever metrics we come out with next year, are they legit numbers? Are they numbers that are actually people feel the difference? And so that's something that we're, as we're in the process and working with other health plans right now, is figuring out what are those metrics. So it's not just about reporting on metrics that always get approved every time anyway, or that for services that nobody ever uses. It's looking at some of the common frustration and pain points and showing how are we making progress towards streamlining prior auth in those cases. The next one is on seamless process for individuals who switch insurance companies, so continuity of care. So when a patient changes insurance companies during a course of treatment where there was a prior auth that was applied under their previous insurer, the new health plan that's covering that individual will honor that prior auth for 90 days. And so that applies for as long as that patient is going to an in-network provider and it is a covered benefit in the new health plan, any previous prior auth that had been put in place by a previous insurer will be honored for 90 days, for those first 90 days with the new insurer, and then revisited at that time. And so we're hopeful that that will also help with another frustration that many individuals have felt as they switch insurance plans from year to year and having to go through prior auth all over again for something that they had to go through prior auth for the first time around. More personalized support and transparency. So this is another big one. So starting in January, plans are going to be providing more clear communication and easy to understand explanations of prior auth determinations. So it also includes support for any sort of appeals or next steps that might be necessary if something wasn't approved. We know that a major frustration is that, and this is for providers as well as patients, something was submitted for prior auth, it gets denied, you get a letter in the mail saying it's not a covered benefit, or it was determined that it wasn't medically necessary, not in your explanation of benefits. And so this is one where plans have committed to improving what we communicate and making it easier for that individual to understand what went into the individual patient as well as the provider, what went into the determination, as well as any next steps. So if there is an appeal that is on the table, how you can go about doing that. So it's not as murky of a process, or it's not a process that will create additional kind of hoops to jump through in order to get a second chance. And so this is another big one that we're hoping will improve some of the member experience along the way. Fast tracking responses for electronic requests. So this is another one that starting in 2027, looking at streamlining. And so plans are committing to increasing the number of real-time approvals for those prior auth requests that are submitted electronically to a minimum of 80% by 2027. So if your provider is sending it in electronically, not by fax, not by mail, plans are committing to get to an 80% approval with all necessary information received on that first pass, 80% approval in real time. And so, so that's something, or 80% determinations in real time. Hopefully that will often be approvals, but that's something that we also think is going to be a major improvement over what we currently have today. And then finally, ensuring medical experts lead prior auth reviews. So this goes back to making sure that a human is always involved in the judgment and any sort of determinations around medical necessity. So if there's a denial based on medical, and so AI is being used to kind of take in the information, make determinations. If there is a medical necessity determination made by AI, that will never be the final say. A human with the relevant clinical expertise will be reviewing that particular case to ensure that, okay, this actually does make sense, and either no, it should not be approved because it's not medically necessary, or yes, this should be approved, and we're going to overturn the AI determination in this case. And so this is what plans are already doing, but we wanted to put it in writing and put it public to double down on that, because we know that there is that concern about the human element of this and the right clinical expertise not being there at the right points along the path where AI ends up making determinations. And so so this is something that we are really hoping as well will help continue to build consumer trust. And so finally, in closing, just some recommendations going forward that I want to share. We strongly support the NAIC's 2023 model bulletin on the use of AI systems by insurers. We thought that it really laid out a clear set of responsibilities for insurers for how we should be governing AI tools. And it kind of found the right balance between accountability as well as allowing for some innovation in the space going forward. I think since its release, 20 plans have adopted this as a baseline for insurers to be governing their AI systems. And so we're hopeful that more will continue to do that. Evaluating the existing AI landscape before pursuing any model law on AI. We do realize, there are concerns, and there's a gap right now between what the federal government's doing, what the states are doing. The states are stepping up to try and fit that gap. And so what we're asking is that, just knowing that the landscape continues to evolve very rapidly, and just in the first few months of 2025, there were about 250 AI-related bills that were introduced across the states. Many of those have implications for health insurers, and so what we're asking here is just ensure that there is a clear need or clear gap that's being addressed before any sort of model law ends up making it in, to help prevent there being sort of a patchwork of approaches across different states and some inconsistencies and confusion in requirements. Also, finally, just we support looking at the risk-based standards that are out there. We support risk-based standards as the foundation for AI oversight. So not all AI tools carry the same level of risk, and not all AI use cases are the same. And so making sure that there is that sort of flexibility in those frameworks that are in place that are being leveraged, and the accountability that's landed on in the end is calibrated relative to the potential for consumer harm. So with that, I just want to thank NAIC for their leadership on this issue. We do at Blue Cross Blue Shield Association and our Blue Plans, we want to continue to be partners with the NAIC and with states as you all look at different regulation in this space, and we want to make sure that AI is responsible. It's done in a way that protects patients, but then also can help us eliminate some of the burdens associated with getting timely access to care. So, thank you.
I just want to thank our panelists for today, and I'm sorry we don't have time for Q&A, but we promise this will be the more sessions on this and more opportunity to talk about it and have questions answered. Thank you very much.